I think I've met most everybody, but my name is Terry Priest, and I work here at the hospital in PR and marketing and community relations. And we have started holding these Health Matters series, education series, and I'm so glad you all are joining us tonight. And we have a great speaker for you, Garrett Tolley. And Garrett has a long list of letters behind his name. And this one right here in the middle, this little RN, he just recently got. We are so proud of Garrett and so excited for all of this. But so I was thrilled when Garrett said, "Yeah, I'd be glad to come do that." So we may get you on the circuit, and we may do this more than once. So just get ready. Anyway, I'm gonna turn it over to Garrett. Thank you all for being here. I hope everybody signed in and watch for more to come. We do this the first Tuesday night of every month. Different topic. We talked about some ways that we might spread the news a little bit differently, and we're going to try and do that going forward. So thank you all for being here. Garrett?
Awesome. Well, again, my name is Garrett. I don't think there's anyone in here who doesn't know me. What we're going to do tonight is we're going to learn about our heart, how it works, some of the different disease processes that can affect our heart, and then what we can do here at Columbus Regional to help your heart health. Now, some of this is going to be a little bit interactive, so I'm going to need you to come out of your shells, and I'm going to need you to kind of interact with your neighbors. I am usually a very active speaker, so I'm usually bouncing around and moving around. So I'm kind of going to expect the same thing from you. If you sit there like a bunch of logs, it's not going to be any fun for me at all. So this is to be fun. Okay, so we're going to enjoy this, but we're going to learn a lot. So to kind of get started, we're going to do a real quick introduction about our heart. So we're going to talk really quickly about our heart so that we kind of know what we're working with. And for those of us who may not know the function of the heart or the physiology of the heart, we're kind of going to do a very quick and brief introduction with that, so that as we're moving forward, everybody's on the same page. So our heart is, at its most simple form, a two-sided pump. So we have the right side of the heart, and the right side of the heart deals with deoxygenated blood, and it deals with the pulmonary flow. So kind of a quick pathway: blood that has been used by the muscles, blood that has gone through the gut circulatory system, blood that has been used by the rest of the body, or systemic flow, will come up from the lower part of the body through the inferior vena cava, will come down from the upper part of the body through the superior vena cava, and that comes into the right atrium. So the right atrium just kind of collects all of that blood that's already been used. On the next beat, the right atrium pushes the blood down into the right ventricle. The right ventricle will contract, move the blood up and out into the pulmonary circulation. Now, this is one of the only times in the body that an artery carries deoxygenated blood. It's pumping that blood away from the heart, which makes it an artery, but it's deoxygenated blood, so it's not useful for anything. So it goes to the lungs, where it drops off its carbon dioxide, picks up a fresh load of oxygen, and it comes back. It comes back through the pulmonary veins into the left atrium. The left atrium contracts, pushes blood down into the left ventricle. You know what, I got ahead of myself. Pushes blood down into that left ventricle. The left ventricle will contract and push blood out to the rest of the body, or what we call the systemic flow. So the left side of the heart, the other part of this pump, deals only in oxygenated blood, and it deals only in systemic flow, which is flow that goes to the rest of the body for utilization. Now, this is our aorta. Okay, this is the largest artery in the body, and the aorta has roughly the same amount of pressure as a standard garden hose. So think about that for a second. Think about the hose that you've got hooked up to your house, and you cut it on and let it flow. That aorta, right at the bifurcation, has that same amount of pressure. Y'all, that's a lot of pressure. That's a lot of pressure that moves through that artery. And then the more simple thing to think is all of this is done by one small little muscular chamber about the size of your fists. Does all of that. Okay? As we're kind of moving forward, again, the heart is a muscle. So cardiac muscle tissue is a little bit different than skeletal muscle tissue, and it's a little bit different than smooth muscle tissue. Cardiac muscle tissue is striated, and only that really means to you is that striated muscle tissue uses less oxygen than skeletal muscle tissue. But it also has a longer endurance life. A cardiac muscle cell can beat over and over and over for the duration of its lifetime. A standard cardiac muscle cell usually lasts around 120 to 140 days. It's actually a long time for a muscle cell. Generally, muscle cells break or lyse usually within about 30 to 60 days. Cardiac muscle tissues, because of the type of tissue it is, lasts a lot longer. Now, I want you to notice a couple of things. If you'll notice the atrium, these muscles wrap in. So what that does, when the heart gets the signal to beat, the atrium, boom, beat in. They pull in. And that causes them to beat from the top down, which makes sense because you're pushing blood from the top of the atrium into the ventricle. But then look at the musculature of the ventricle. It's one solid piece, and it wraps up and it connects at the atrioventricular septum. And if you'll notice that, when that beats, that's going to beat from the bottom up. Now, cardiac muscle tissue is electrically based. So if I'm a cardiac muscle cell and I'm sitting here and I beat, I cause this one to beat, which causes that one to beat, which causes that one to beat. So they kind of go in a wave. Sort of think of like a football game where they start the wave. That's basically how your heart beats. Every single contraction, you get an electrical stimuli. This muscle cell contracts, which causes this one to contract and this one to contract. Okay. So what we're going to do now is we're actually going to make a heartbeat. So I'm going to show you guys how this heart works. Now, I don't have quite as many people as I was hoping, so what we're going to do is we're going to start on this end and we're going to work on that end, and you guys are going to be our ventricles. Okay? So you're going to be happy, excited little muscle cells, you're going to be happy little cardiac cells, and you're going to cause each other to beat all the way down. Now, this is very, very important. You've got to get this beat right, because if we don't have a beat right, that's called an arrhythmia. And what do we do to arrhythmias? The newest nurse in the room. This is my friend Audra. She graduated with me from Southeastern Nursing School, and she just got her RN this week too. So we're very proud. If we have an arrhythmia, we have to shock it. Nobody in here wants to get shocked, so y'all better be right. All right? So we're going to start on this end, and this is how I want you to do your contraction. This muscle cell is going to start. You're going to contract and hold. There you go. You're going to contract. Go, 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 go. That is what we call depolarization. That's contraction. Now, don't y'all reset yet. The next part of the contraction is called repolarization. That's where everybody pulls back in to get ready. So you're going to start it this way and go all the way back. All right? Depolarize. Go, 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 go. That is one heartbeat. That's exactly how it works. So repolarize. Go, 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 go. Depolarize. Go, 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 go. Very good. All right. That's a heartbeat. Now, y'all remember that, my happy little heart cells, because we're going to have to do that again. So this is a brand new heart. This baby's just been born. That heart's beating, 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 beating. There's nothing that's going to stop it from beating right now. It's electrically patent. It's got plenty of blood flow. It's very healthy. That's what normal, healthy heart tissue does. It beats in and out all day long. Okay? All right. Generally, the heart beats around 60 to 100 times a minute. That's what we would call a normal rate or normal sinus rhythm. Now, certainly a heart can beat faster than 100 times a minute. Generally, as long as the heart is healthy and we've got a normal rhythm, that's what we would call sinus tachycardia. Sinus meaning normal rhythm, tachycardia meaning fast heartbeat. Any heartbeat that beats less than 60 beats a minute and is still normal is what we would call sinus bradycardia. Sinus being a normal rhythm, bradycardia being a slower heartbeat. Okay. This is actually a very nice, pretty sinus rhythm. Okay. So, how is all of this controlled? The heart is actually a very fail-safe mechanism. There are several different control mechanisms to control how fast this heart beats, how hard this heart beats, if there's any change in the beat pattern, if there's any change in the rhythm. A lot of this is controlled systemically or through the brain. So if you'll notice, we have the vagus nerve or the parasympathetic system, which actually will cause your heart rate to increase. Okay? Now, a lot of different things can affect that vagus nerve. Let's say we get really excited. Let's say we get really angry. Let's say we get really scared. Your body releases endorphins, your body releases epinephrine, and that stimulates the vagus nerve, which speeds that heart rate up. Okay? Now, let's say we're at the beach, we've got our favorite drink, it's nice and sunny, it's nice, got a cool breeze, you're hearing that ocean wave, it's just very relaxing. That actually stimulates the parasympathetic or the sympathetic nervous system, and that just slows that heart rate right on down. Okay? Nice and slow, nice and relaxed, soft, easy contractions. We're not putting any stress on the heart, we're not putting any demand on the heart, so it can just kind of relax a little bit. It still has to beat to keep us conscious, but if it's not going to beat hard and fast, it's not going to. Okay? Again, there is some neural control, so the brain does have some control as to what this heart does, how it does it, when it does it. But the heart also, there's a lot of, the heart actually has its own control systems. Okay? So let's say, for instance, this is a horrible situation, but it happens. Let's say, for instance, that someone gets in a car wreck. And let's say that they break their neck. Okay? Well, I want you to look at where this nerve comes from. Okay? The sympathetic or the parasympathetic nerve starts around C3 and C4. If you break that neck, now all of a sudden you've injured that nerve root that goes to that heart. If it's high enough up, that can be instantly fatal. If it's around C3 or C4, your heart's secondary control mechanism will kick in. The heart can actually beat on its own accord with no outside input from the brain at least 60 beats per minute. Okay? So that's what we would call a junctional rhythm or a junctional rate. So the heart's going to beat just enough to keep you conscious and to keep you patent, to keep that blood flowing. Okay? But it's not really going to be enough to sustain any type of activity. Okay? But it gets even further than that. Okay? The autonomic control mechanisms of the heart actually starts on the cellular level. Now I want you guys to watch this. These are heart cells that were actually scraped off of the heart, placed in a petri dish, and as long as those heart cells have oxygen, as long as those heart cells have nutrients, the autonomic control mechanisms at the cellular level will allow the heart cells to beat on their own. Now, a really cool story, when I was at Campbell working on my undergrad degree, one of the classes I had to take was cellular biology, which just sounds like fun, don't it? Just sounds like a great class. In that class, we actually isolated out chicken embryo heart cells, and we grew heart cells in petri dishes. And basically our professor said everybody who can incubate their heart cells to a full plate gets an A for this project. You have to be very careful. You can't get any kind of fungus or bacteria in there because they'll take over the petri dish and actually damage the heart cells. It is mind-blowing to sit there and watch a bunch of cardiac tissue beat in the bottom of a petri dish. Now you'd have a clump over here and a clump over here and a clump over here, and they're all just doing their thing, they're all just beating, but they'll grow. And as they grow and they continue to beat, when they touch each other, now they start beating together. By the end of the program, most of us had a full petri dish full of heart cells that would just beat from one side to the other, back and forth, and you could watch the liquid just move. So it's crazy to think that we have a pump in our body that can basically work on its own, monitor itself, and continue to keep us alive if need be, as long as it has what it needs. Okay? All right. On any given day, the average heart beats 100,000 times on any given day. The average heart will pump 2,000 gallons of blood a day. That's a lot of blood. But it's kind of hard to wrap your head around, isn't it? 2,000 gallons. It's kind of hard to make that visual stick. So check this out. That is a 2,000 gallon pump truck. Every single day, that little ball of muscle pumps enough blood to fill that truck up. Every day. 365 days a year for as long as you are alive. That is a lot of work. The interesting part about all of this is as much work as this heart does, a lot of times we really forget that we even have a heart. Unless it comes up and causes some kind of issue, or unless it pops up and there's a problem, we forget we have a heart. And that makes our little heart so sad. So part of what we're trying to do tonight is I want to get you guys educated on, one, we've talked about how the heart works. Very rudimentary, but we still kind of have an understanding as to how this thing is working now. So what can we do to keep it safe? What are some diseases that we kind of need to keep an eye out for? Okay.
I thought you was asking.
Oh. So, I do want you to look at this. This is the vasculature of the heart. So, because the heart is a muscle, the heart has to have its own blood supply. It can't continue to function if it doesn't have nutrients and if it doesn't have oxygen. Just like the muscles in your arms, just like the muscles in your legs, any biological tissue has to have a nutrition supply and it has to have an oxygen supply. Where do we get that in the body? This is not a rhetorical question. We get it from the blood. That's what carries our nutrients and that's what carries our oxygen. So every organ, every muscle, every little skin cell, every little hair follicle has a designated blood supply. So does your heart. The vasculature of the heart is actually one of the most thick capillary vasculatures of anywhere else in the body, secondary to the brain. It's almost a solid mass of tissue. The reason I show you this is because the biggest problem with our hearts starts in these vessels. Any idea what that might be? Shot in the dark? Anybody? Judy? Plaque? Somebody said it. There you go. Plaque. Which plaque actually leads to a condition called coronary artery disease. Coronary artery disease is the #1 killer in this country. Coronary artery disease kills more people annually than all forms of cancer combined. Think about that, because all we hear is cancer, 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 cancer. Heart disease kills more people every year than cancer ever has. On average, every 40 seconds, somebody in the United States dies from heart disease. This presentation is slated to last an hour. The time that we're in here, 90 people across the United States will die from heart disease while we are in here tonight. Think about that. That's a staggering number. In 2017, approximately 800,000 people died in the United States alone. This is not worldwide. This is just the continental United States. For whatever reason, they do not include Hawaii and Alaska when they do these. I don't know why, but they don't. They don't. They really don't. I think it's because the sparsity of the population. I'm not sure. Approximately 800,000 people in the continental United States died last year from heart disease. That's more than the entire population of the state of North Dakota. In 1 year, an entire state's population, gone, just wiped out. One would think that as substantial as this is, and as prevalent as this is, that we would hear more about it. But unfortunately, you don't hear a whole lot about heart disease anymore. There was a big push in the 80s and 90s for heart disease, and then cancer kind of came to the forefront. So one of my goals tonight is to make sure that when you leave here, that you've kind of got heart disease on the mind. Okay? So what can you start doing to change in your lifestyle so that you don't become one of these statistics? We all gonna die. I want you to die of something else than heart disease. All right. So this biggest killer is coronary artery disease. And coronary artery disease is basically just a condition in which plaque builds up inside the coronary arteries and blocks that flow. I wish it was more deep than that. I wish it was more complex than that, but it's not. That's at its simplest. That's really what coronary artery disease is. But now let's talk about plaque for just a second. Plaque is a very waxy, fatty substance. This is where your Crisco comes into play. Crisco is the closest thing that we have to what, play in your Crisco and pass it down. It's the closest thing that we have to an illustration of the plaque that's in our arteries. Plaque is fats, cholesterol, calcium from the blood products, platelet products that basically get bound into this substance and then start to lay down a blockage in an artery wall. So this is a bisection of an artery that actually has plaque in it. At your body temperature, plaque is solid. If you move your body temperature up by 5 degrees, plaque starts to liquefy because it is at its most simple level fats. Dietary fats that are soluble. So we primarily get plaque from the foods that we eat. Foods that are high in saturated fats, foods that are high in trans fats, and foods that are high in dietary cholesterol. Generally, any oil or any fat that is solid at a room temperature, like our Crisco, can actually lead to the increase of dietary cholesterol and lead to the increase of fat deposits in the artery. Inactivity, poor dietary habits will also increase the rate at which plaque is deposited into the arteries. But now go back and look at this picture real quick. If you'll notice, for the most part, the inside of this artery is pretty smooth. Well, once you have a plaque buildup in the artery, your body tries to absorb that because it's now an obstruction in a blood flow pathway. And your body doesn't really want it there. So what your body will do is it will lay down what we call a fibrous cap. Tissue that's connective tissue. It's a little bit of epithelial tissue, but it tries to cover that sticky, jagged mound of plaque that's built up in the artery. Keep that in the back of your mind because that's going to be important in a few minutes. So just stick that back there. Okay? Coronary artery disease, again, these arteries are very, very important because they're what supplies blood flow to that heart muscle itself so that that heart can continue to beat, to continue to provide you with oxygenated blood flow and to continue to keep you alive. Now, we talked earlier about the artery that comes off the heart having roughly the same amount of flow as a garden hose. Well, as we continue to build plaque up in that artery, the diameter of that artery begins to narrow and shorten, narrow and shorten. Okay? Well, think about that for just a second. If you've got a garden hose and I start to kink it off about the middle of it, you're not going to get as much flow out of this end, but flow on this end is going to start to back up, right? Our hearts do the same thing. This is one of the ways that heart disease and coronary artery disease kills people. It actually falls into one of the heart failure categories where you start to have a backup, and that backup is called
CHF?
It's CHF, but that backup is called preload. So there you go. I'm putting her on the spot. I pick on her.
You got me.
Okay. So kind of look at the progression of heart disease. We have a normal artery. It's nice and smooth. It's nice and open. Blood flows through it very easily and at a good high volume. We're starting to have some very early injury in the very early onset of this coronary artery disease. So as this starts to build up and this flow becomes less and less and less, look at what's happening to the tissue, the muscle tissue of the heart. It's starting to receive less and less blood flow, which is going to make it weaker. It's going to make it not as reactive. And that particular section of the muscle tissue can actually start to die. Okay? So, we're going to go back to our heartbeat. So I want all my happy little heart cells back. All right? Smile, smile. I want happy heart cells. You don't have very much blood flow. You don't have very much blood flow. You don't have very much blood flow. Because the artery that feeds you has got a blockage in it. So you three muscle cells, you three heart cells are not the most happy heart cells we have in the room. You're kind of weak. You're kind of slow. You're not reacting very well. So when our heartbeat starts, it's slow, it's weak, and then it continues on. Okay? When it goes back through, slow, slow, normal, 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 because you guys have got full active blood flow. You're healthy, happy heart cells. As simple as that is, that truly is heart disease. That truly is how it works. Okay? Heart disease can very quickly go from a very bad situation to a much worse situation. So we've already got an area of muscle tissue that's damaged. We've already got an area of muscle tissue that is just weak. Okay? Now let's think, I went too far. Now let's think maybe we're not taking care of ourselves as much as we should. Okay? So if you have a section of your heart that's weak and you have a section of your heart that isn't working as efficiently, honestly, how are you going to feel? Tired, weak, sluggish, short of breath, right? That's truly how you're going to feel. All the way down at the cellular level, that's really what's happening. Those cells are tired, those cells are weak, they don't have a lot of energy, they don't have a lot of nutrients. So because of that weakness and because of that decrease in perfusion, your heart's not putting out as much blood as it used to with every pump, right? So your body, sensing that, tries to correct that. You may have a little bit higher heart rate. The other muscle tissue that is getting a good blood flow, now you have to beat a lot harder than these three that don't have a lot of blood flow to kind of help take up the slack. What that will eventually lead to is a condition called hypertension. Hypertension is high blood pressure. So if you have uncontrolled hypertension, you've got blood that's rushing through these arteries at a much higher pressure than they were originally intended to, this thin fibrous cap one day may rupture. Okay? Now our body has laid down a thin fibrous cap over that plaque so that blood just flows right over top of it, keeps right on going. But now we've got that thin fibrous cap that has torn because it just can't take the pressure anymore. It finally tore. Now we've got sticky, thick, gooey plaque that's exposed to all of these little blood cells that are passing by. What do you think these little blood cells are going to do when they hit this sticky, thick goo? They're going to stop. Just like a pileup on a freeway, this one piles up behind this one, piles up behind this one, piles up behind this one. And eventually, no blood gets through. So now the three of you, you have that weak heart rate, or you have that weak blood flow. Excuse me. Now you have formed a clot. Okay? No blood is any longer, no blood is getting through that artery. So the three of you here, you no longer have a blood flow. Okay? You are what we call ischemic. You are having a heart attack. That part of that tissue, that part of that heart cell will start to die. Those cells will release triggers. Those cells will release chemicals. Those chemicals we test for when we suspect a heart attack are called troponin. That's one of the most common chemicals. That's one most people know. That's actually where that comes from, is blood or heart cells that are kind of in an emergency. They need help. Okay? So now that we have a complete blockage, we don't have any blood flow anymore, you three can't do anything now. So start my heartbeat. Go, 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 stop. Now, if there is enough, wave it and keep it going. If there's actually enough electrical stimulation for that beat, the others may pick it up. If there's an area of damage that's larger than that, they won't. That beat stops. But you're still going to repolarize because you've still got to go. So repolarize, go, go, go. And then it would start over. But now because we actually have this heart attack in process, we have an area of this muscle tissue that is so weak it can no longer contract. It can no longer move that blood through like it's supposed to. It's really bad for our heart. It's even worse for us. Okay? So that's, again, what we call a heart attack or a myocardial infarction. And that, at its most simplest, is when the blood flow to a section of the heart muscle becomes blocked completely. Think about putting a Band-Aid on or a rubber band on your finger. If you put it tight enough and stop the blood flow, eventually the tissue past that rubber band is going to die. Same thing with your heart. If we don't get something done with that clot, if we don't get some blood back to that muscle tissue is going to die. And guess what cardiac muscle tissue does not do? It does not regenerate. It does not. But luckily, the rest of our heart tissue can help to pick up the slack, but you will always have that area of what they later call scar tissue. Okay? Heart attacks are really bad, and they generally kill people for one of two reasons. The first one I'm really not going to go into because it's a lecture in and of itself, is heart failure, which is basically a condition where the heart simply cannot pump enough blood through the body to keep you alive and to keep all of your other organs functioning properly. So you start to have organ shutdown and things just kind of go from, again, bad to worse. The other thing that we see most frequently is caused by arrhythmias. Okay? So let's say now that you guys, you're not beating anymore, you're in desperate need here, you don't have any blood flow any longer. But let's say this group over here now they're trying to do something. So they're trying to help. They know that there's an issue going on, so now they start beating. But now you start beating. But now you start beating. So everybody beat. Just beat. Beat, beat, just beat. No, you're dead. Just beat. Exactly. Stop. That's what we call fibrillation. All different areas of the heart are trying to beat at the same time because the heart knows that there is something going on and it's trying to get it to work, but it doesn't have that nice organized rhythm. It's fibrillation. It's just quivering. As one of our professors said, it looks like a bag of worms. It's just quivering. It doesn't move any blood. It will not restart itself. When you have something like ventricular fibrillation, the only thing you can do, shock it. Shock it to restart it. Okay? So, as scary and serious as all of this is, I'm kind of trying to keep it light. Oh, y'all weren't supposed to see that yet. Trying to keep it light. So we know that that's a heart attack. Fortunately for us, and we have to give kudos to Columbus Regional, because fortunately for us, we are in what we call part of the RACE program, which is centered through New Hanover. We now have our life flight choppers here. We can respond to these and do what they call door to balloon or door to dock time, usually in around 90 minutes, which is the golden hour. Okay? So reperfused, get that clot taken care of, get something going. You can generally reperfuse that muscle enough that it becomes patent again. It may be a little bit weaker, but it's still functional muscle tissue. Okay? So, when we have a heart attack, what are we looking for? Generally, most of us think when we have a heart attack, we always think of the Fred Sanford, "I'm coming to see you, Elizabeth." That's generally what we think of when we think of the heart attack. Big grand show, lots of chest pressure, lots of pain. For the most part, those are relatively accurate. We do see a lot of chest pain and pressure. A lot of my patients will tell you it felt like my chest was in a vice. We see a lot of that. Neck pain, pain in the jaw, pain in the upper back, pain in the shoulders. You'll also get, obviously, some shortness of breath because your heart can't pump enough to perfuse an adequate amount of blood through the lungs, so you're going to be a little bit of short of breath. You've got more carbon dioxide on board than you do oxygen. That's going to stimulate you to try to breathe more and blow that off. You're not going to be able to do that. So you're going to have some of those shortness of breath issues. Dizziness and lightheadedness because you've got a decreased blood flow through the brain and you've still kind of got that whole hypoxia thing going on. Okay? Nausea and vomiting. Diaphoresis, which is just intense sweating. Those big, just crocodile sweat drops. Those huge, wet, cold sweating. Diaphoresis is not a normal, moist and glistening. Diaphoresis, you are dripping sweat. It pours. Okay? A lot of patients also have anxiety or a sense of impending doom. There is something bad going on. Help me now. Okay? Now, these are accurate. And it's okay to think of Fred Sanford. But here's the other side of this. These aren't entirely accurate for everyone. Okay? Men are from Mars, women are from Venus, right? Everything about us is different right down to how we manifest heart problems. Women do not have typical cardiac symptoms. Okay? Go back to Fred Sanford. Our big male cardiac, most men present with Fred Sanford-like symptoms. Most women do not. Some of them are the same, some of them are different. Okay? The chest pain and discomfort, roughly the same. Men tend to have more rapid and irregular heartbeats. Men tend to do more of that drop-dead heart attacks. Have a heart attack, have a clot, throw an arrhythmia, done. And if there's no AED, you're gone. Men tend to do that more than women. Not really sure why, actually. There's a lot of research that suggests one reason or the other, but nobody ever agrees, so we just say, I don't know. Okay. Men tend to feel a little bit more dizzy and lightheaded. Again, we have that diaphoresis. the stomach and indigestion upset, and of course the shortness of breath. Women have the shortness of breath. Women do tend to have the nausea. Women also tend to have more of their pain in their upper back, in their neck, in their head, or epigastric, which is why a lot of women go, I just thought it was heartburn. I hear that a lot. A lot of my female patients tell me, I thought it was heartburn. I really did. I never thought it was my heart. I didn't feel that crushing pain. I didn't feel that elephant sitting on the chest like everybody says you will. Women tend to present their heart symptoms a lot different. Women tend to have more anxiety and sleep disturbances. Now, I'm going to get on my little soapbox here for just a second, okay? And I'm talking to the women in the room. Men, y'all just hang out. Ladies, if you feel like you are having any kind of heart issues, if you feel like something is going on with your heart, go get it checked. Advocate for yourself. Women tend to have a lot more anxiety and agitation with their heart attacks. So doctors are very quick to go, she's having an anxiety attack. Here, take this Annex, call me tomorrow. A lot of times tomorrow doesn't come. That's kind of a joke, that's a grand illustration, but people, it happens a lot. A lot of my female patients tell me, I went to the doctor, he said it was this, he gave me this for anxiety, he put me on Zoloft, he put me on this. It was their heart all along. Okay? Advocate for yourself. Women do not present their heart symptoms like men present their heart symptoms. If you know there's something going on, speak up. Get angry if you have to, get loud if you have to, but do what you have to do to make sure that you get the treatment you need, because it could save your life. I'm going to get off of my soapbox now. I hear this a lot from my female patients. I see this issue a lot. It means a lot to me. So I am a little bit more passionate about that. So make sure that you're getting your heart taken care of just like the men. Okay? Now, I'm going to throw this in here. You don't have to pay attention to this if you don't want to, but who are my dog lovers in this room? I cannot be the only one. All right, good. I know you don't. You love Molly.
I love Molly.
All right, my dog lovers. I ran across this and I had to put this in here. I had to include it. Our dogs have heart attacks too. These are some things to kind of watch out for in your dog. And I read up a little bit more on this. Shortness of breath, breathing problems, and excessive panting. They'll also excessively drool and try to bite at their left side. They're sore in their forelimbs and try to guard those forelimbs. And they have obvious pain and discomfort. Now, if you suspect that your furry little loved one is having a heart attack, it is okay to give them an 81 milligram aspirin and rush them to the bed. Okay? I had to throw that in there. I just threw that in there for free. Okay? Now, if you feel like you're having a heart attack, or if you feel like somebody that you know or love is having a heart attack, very, very quickly is how you should act. Okay? Do not ignore these symptoms. Call 911 immediately. Chew a 325 milligram aspirin, chase it with a half a cup of water to make sure that it all gets down and it starts to get absorbed. Okay? Remain as calm as you can, because we don't want to stress that heart out. And if you're running around upset and crying and boo-hooing and bouncing around, you're just putting more workload on that heart that's already taxed to the breaking point. So relax, stay as calm as you can, keep your family as calm as you can, and wait for help to arrive. Okay? Now, if someone you see is unconscious, if they go unconscious, then you need to perform bystander CPR. Now, most people, if they see someone unconscious, do not perform bystander CPR. Why? Say it again?
Don't know how.
Don't know how. What else? Why? What would keep you from doing CPR on somebody you see out in the street?
Don't want to get involved.
Don't want to get involved. Most people say, I don't want to breathe. I don't want to put my mouth on them. I don't know them. I don't want to do that. I don't know if they have any diseases. I don't want to do that mouth breathing for them. A lot of people who have witnessed heart attacks don't do CPR, and when they're asked later why, that's the reason. The majority of people don't want to breathe. Well, good news for you. You no longer have to breathe. Okay? The American Heart Association came out with what they call bystander and rescuer only CPR, compression only CPR. So what you'll do is you push hard and you push fast in the center of the chest. That's it. You don't have to worry about placement. You don't have to worry about pulse. If someone is unconscious and you cannot get them awake, if you don't know how to check a pulse, don't check a pulse. Start doing bystander CPR. Push hard and push fast, around 100 beats a minute. The easiest way to know if you're doing it right is sing that famous disco tune, Staying Alive, because that has 100 beats a minute. If you can sing that song and you sing it like it's written, staying alive, ah, 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 that's 100 beats a minute. Okay? That's what it works out to. If you see someone that you think has had a heart attack and you know needs your help, jump in, lay them on their back, find the center of that sternum, and start compressions. Okay? Don't worry about whether they've had an open heart surgery. Don't worry if they have any other issues. If you're comfortable checking a pulse, check a pulse. If you don't feel one, do that CPR. Okay? It could very well save somebody's life. Okay? So, we've talked a little bit about the heart. We've talked a little bit about coronary artery disease, how it is, the mechanisms, what it does. So, what are some of the treatment options for coronary artery disease or heart disease? First, we have medication management. Now, that's generally a long-term medication management for patients who have a chronic but stable condition. Okay, the rest of these are more acute. Okay, so if we have a patient that presents with acute angina that we suspect is a heart attack, and we do see, then we can do clot-busting drugs that will break up that blood clot and allow blood to flow back through that artery and start to feed those cells again. So you start to get some reperfusion there. Okay? We can also do a coronary angiography or coronary angioplasty. We can do coronary stenting and then coronary artery bypass grafting. Okay? So kind of go through some of these. Angioplasty basically uses a small catheter that's threaded through usually the femoral artery in the groin, but now a lot of physicians are actually going through the wrist. So they're doing femoral artery, wrist artery insertions, threading this catheter straight to the heart, finding that blockage, inflating that balloon that pushes that plaque up against the wall, opens that artery back up, and blood can very easily flow back through. Okay? Now, I will tell you from the clinical side, I very rarely see a patient that has had an angioplasty. I had one in 2017. Out of all of the patients that I admitted to my program, I had one angioplasty. You don't see these done very often. The reason it's just kind of a quick fix. It usually doesn't last very long. So that leads us to our next favorite. Oh, actually, I'm sorry. I got ahead of myself. So you place that small balloon in. It runs through the arteries. You go to where the clot is, inflate that balloon. Usually it's with saline. That balloon inflates, pushes that plaque against the wall, deflate the balloon, out you go. You've restored that blood flow, that muscle is now reperfused, everything should start to normalize. But look at this, how long do you really think that's going to stay that way? Okay, it's kind of rare. So we don't see these very often anymore. Generally what we will see now are stent placements. Now, stent placements is basically an angioplasty with a small stent on the outside of that balloon. The stents are made out of titanium and different titanium alloys. They're very strong, they're very rigid, but they're also very flexible. Once they're inflated and they lock into place, they very, very rarely deform or collapse. Now, it does happen on occasion. I think I've had 2 patients since I've been practicing whose stents collapsed. It's very rare that that happens. So they will thread that catheter in, again, through either the femoral artery or through one of the arteries in the wrist. Inflate that balloon, which stretches that stent out. That stent locks into place. They deflate that balloon, pull the catheter back out, and you're left with an nice open patent artery with a stent matrix that holds that blockage against the artery wall and holds that artery open. Okay. So on the tip of a finger, these are the stents we're talking about. Okay. Tiny, tiny little things, very flexible, but at the same time extremely rigid. Okay. Coronary artery bypass grafting is generally done for patients who either have blockages that you cannot get a catheter through, and stent placement is usually our go-to. We would rather do that than anything else if we can. It's it's minimally invasive. The downtime is usually 24 to 48 hours with a few restrictions after that. But for the most part, if we can do a stent placement in an occluded artery, that's what we would rather do. Sometimes that simply isn't feasible. If you have an artery that is blocked with plaque 100%, you're not ever going to get a catheter through that. You just can't punch through it. The only other option is to go the bypass route. So basically what they do from a bypass is they will harvest veins, either an artery or an actual vein, from different parts of the body. Now they can take those from the forearms, they can take those from the legs, or they can use the mammary arteries on the inside of the chest wall. Take those arteries, find that blockage, bypass above that blockage, and reperfuse the heart tissue that way, or below it, excuse me, I apologize. Go below that blockage and reperfuse the heart tissue that way. Okay? So we have a blocked artery here, we have decreased blood flow here, so we're starting to have some tissue and cell death here. So we've harvested a vein and we've harvested an artery. You'll attach those veins and arteries to the aorta, which again has the highest blood flow of freshly oxygenated blood in the body. So if you're going to get blood from somewhere, that's the best place to get it. We'll find those blockages and literally bypass that blockage so that the heart now has good, healthy blood flow from here down to the blockage and from the blockage through the graft here down to the rest of the heart. Okay. Does that make sense? Any questions? Okay. Now, from a risk factor standpoint, anyone who has coronary artery risk factors, generally the more risk factors you have, the more each risk factor means. Okay, the more it weighs. There are many different risk factors when we're considering coronary artery disease. And those risk factors generally fall into 2 categories. They fall into modifiable risk factors and they fall into non-modifiable risk factors. So for us, non-modifiable risk factors are going to basically be things that you just cannot change. You cannot change your age. Ladies, you can say you're 39 this year and 39 this year and 39 next year and 39 the next year. That really doesn't change the fact that you're 42. Okay? You can say that, but it just doesn't change anything. We cannot change our age. And the truth is, the older we get, the more susceptible we are to developing coronary artery disease. We cannot change our sex. Okay? If you are biologically male or biologically female, your heart is biologically male or biologically female. Males are biologically more predisposed to coronary artery disease than women, But women tend to get coronary artery disease more than men do. And women actually tend to have coronary artery disease that progresses further than men's will progress. And the reason is, kind of from a medical paradigm, we think any little hiccup at a certain age, we think, oh, well, you need an EKG. Most women, any little hiccup, oh, well, you just need some hormones. Sorry, but it's the truth. So women's heart disease tends to be ignored a little bit longer. So yours tends to be a little bit more severe than men's. Men's call earlier. Okay? We also cannot change our heredity. If you have a strong family history of heart disease, chances are pretty good that at some point you will develop coronary artery disease in your lifetime. Which leads us to our modifiable risk factors. These are things that you can change. Okay? Exercise. We can all change how active we are. We can all change our activity and exercise habits. And it has been proven time and time again, the more you exercise, the healthier your heart is, the less likely you are to develop coronary artery disease. Okay. Comorbidities such as high blood pressure. We've already seen what blood pressure can do to a weak fibrous cap on a plaque buildup. Diabetes. If you are a diabetic, work very, very hard to monitor and control your diabetes. If you are a diabetic, you are 33% more likely to develop coronary artery disease than someone who has the same risk factors as you do, but isn't a diabetic. 33% is a pretty big number. Okay. Of course, our weight. The less weight you carry around, the less work your heart has to do, the less stress you'll put on your heart. Okay. And again, stress. Nobody in here is stressed out, right? Nobody in here is worried about that. Okay. Our hearts are very, very susceptible to the stress hormones that circulate through our bodies. Again, that kind of feeds back to that sympathetic and parasympathetic neural control that we talked about earlier. So, life's too short to worry over all the little things. Okay? It's not good for your heart. Okay? Diet is the single most important modifiable risk factor. Now, we want to choose foods that are high in fiber, but are also high in lean dietary protein. Okay? Most of people get their protein from meats. You want to make sure that the meats that you're choosing are good, lean meats. We don't want to add dietary fats if we can avoid it. Make sure that you're eating fats that are low in saturated and low in trans fats. Okay? You also want a diet that's low in sodium. We know that water follows salt. So if you go out tonight and you have that good Chinese dinner and it's just loaded with MSG, which is sodium, and it's loaded with table salt, you're going to retain more fluid. The more fluid you retain, the more fluid your heart has to handle. The more fluid your heart has to handle, the higher your blood pressure is. The higher your blood pressure is, the higher your increased risk of coronary artery disease is. Okay? It's a vicious cycle. It's a vicious cycle. Stay away from that Chinese food. Okay? Cholesterol. Generally, we want our total cholesterol numbers to be less than 200 milligrams per deciliter. Your LDL, which is your bad cholesterol, that's that little devil down there in the corner. Your LDL cholesterol is directly linked to plaque buildup in the arteries. Okay? That LDL, that bad, sticky, gooey, gummy plaque, that's where most of that comes from. You generally want that to be less than 100 milligrams per deciliter. HDL, which is your high density, which is your good cholesterol. For women, we want that higher than 50. For men, we want that higher than 40. Okay? And your triglycerides. Okay? Generally, we like to see those less than 150 milligrams. If you can keep those cholesterol numbers down, if you can keep those triglyceride numbers down, that actually cuts a big chunk of your coronary artery disease risk factors right out. Okay, so work on keeping those down, work on keeping those very well controlled. Diet is one of the easiest ways to control those. Activity and exercise is also one of the easiest ways to control those. A good aerobic exercise program is linked to decreased coronary or to decreased LDL and an increased HDL. Okay, so your HDLs come from your synthesized in your body, but they're I cannot say that word. They're synthesized while you're exercising. They're never synthesized at rest. They're only made when you exercise. You also get those from plant sterols. So a good high fiber diet, again, is going to help you to have good HDLs, which is going to keep your overall cholesterol levels lower. Okay. Smoking, again, that is the other single most important modifiable risk factor. If you are a smoker, if you are a tobacco user, consider joining a smoking cessation class. Okay. Of course, we all know that tobacco products contain nicotine. What most people don't know is that nicotine as a chemical agent actually has vasoconstrictive properties. High enough doses of nicotine can actually stop flow of blood through different arteries. It can cause those arteries to contract to the point that you have an occlusion, almost as if you were having a heart attack. But there's nothing there. Okay? That's why we always include coronary artery or smoking cessation in our cardiac rehab program for our patients who are active smokers. Because nicotine for a fresh patient who has just had a coronary event is extremely dangerous. It can cause vasoconstriction. It can actually cause arterial spasms, and patients start to experience angina, chest pain, and some similar symptoms to a heart attack. They also have tar, literally tar. Pass that around. That's my famous little jar of tar. If you smoke one pack of cigarettes every day for a year, that's how much tar would accumulate in your lungs in 1 year. You think of people that smoke 2 and 3 packs a day, but they smoke 2 and 3 packs a day for years. Years and years and years. Okay? There are over 100 different chemicals that are known to be in cigarettes that are known carcinogenics. I found this picture and I had to put it in there. I want you to think about it for just a minute. It's a very poignant picture if you really stop and think about it. Okay? I just wanted to include it. I just wanted you to see it because to me this picture speaks volumes. When you smoke, not only do you have those vasoconstrictive issues, but you're also entering into all of those other I cannot talk tonight. Thank you guys. You're entering all of those into your body. All of those directly affect your heart health. Okay? Now, as you inhale the smoke into your lungs, that blood that is being pumped through the lungs goes directly back to the heart. So what do you think the largest organ depository of carcinogenic compounds from cigarettes, nicotine and tar is secondary to the lungs? Your heart. That's the next organ that encounters all of that blood that has just been infiltrated with tar, carbon monoxide, and these other chemicals. So if you quit, there's actually a pretty quick little timeline that starts to progress. 20 minutes after giving up cigarettes, 20 minutes after putting one down, okay, the heart rate and the blood pressure begin to come back to a normal level. Okay? Because again, we know that nicotine is vasoconstrictive. If it constricts those arteries, what's going to happen? You're going to have higher blood pressure. Okay? It's going to rise. 12 hours after quitting and the levels of carbon monoxide in your blood have dropped back to a normal level. Okay? 2 weeks after you quit, circulation in the lung and lung function starts to improve. Okay? 1 to 9 weeks after you quitting, smoker norms like that chronic hacking cough, that shortness of breath with activity, all of that starts to subside. So as you're able to perfuse that oxygen and carbon dioxide through that lung tissue and back to the heart, your heart can now more effectively pump that fresh oxygenated blood to the rest of the body. The body doesn't tend to suffer as much from long-term low-level chronic hypoxia in as little as 1 to 9 weeks. Okay? And then there are a few others that kind of progress here, but I'm not going to read all of those. If you are interested in this, if you would like this slide, let me know. I can print it out for you, no problem. Okay? Exercise and activity. Again, one of the most easy things that we can use to attack that coronary artery disease and start to make those positive changes. Now, when we exercise, our heart rate goes up. When we exercise, our blood pressure goes up. When we exercise, our hearts begin to contract with more force. More blood is ejected with each contraction. The more you do that, the more you perfuse the heart muscle itself, the more you perfuse the vasculature throughout the rest of the body. So increasing your activity and increasing your exercise is a really easy way to start to cut down some of those coronary risk factors. Okay? Generally, the American College of Sports Medicine, the American Heart Association, and the American College of Thoracic Surgeons, they all got together and agreed on this, believe it or not, that the average American should exercise 35 to 45 minutes most, if not all, days of the week. Now, the easiest way to start that is a good 35 to 45 minute walk 3 times a week. That's an easy way to start. That's one of the reasons our program is set into Monday, Wednesday, Friday. Because we're taking historically sedentary individuals who have now had some type of heart event and we're starting to train them into an aerobic exercise program. So, know those numbers. 35 to 45 minutes of continuous aerobic exercise most, if not all, days of the week. Start with 3. A couple of weeks, work up to 4. A couple more weeks, work up to 5. Stress. Again, we talk about those stress hormones, epinephrine, norepinephrine, cortisol. All of those stress hormones that we get when we're aggravated, when we're tired, when we're scared, when we're irritated, can directly affect that heart. Okay? They're going to increase your heart's rate of contraction. They're going to increase your heart's pressure of contraction. And again, if you already have coronary artery disease, you're just increasing your risk for heart attack. You're increasing your risk for vascular damage. So again, if it's not something big and major, if it's something that you can just kind of let go, let it go. Okay, life's too important and life's too short to stress over all the little things. Okay, which brings us to, what do you do after you have a coronary event? Cardiac rehab is the answer to that question. Okay, cardiac and pulmonary rehab is a comprehensive program. So it's actually a program that involves all of these different risk factor modifications. It involves education. It involves dietary counseling. Okay, it involves aerobic exercise. Again, at our foremost. It is a multidisciplinary approach, so you have cardiac physiologists such as myself, you have registered nurses, like my 2 nurses that work so well with our patients. You have dietitians that work with us. We have emotional counselors and stress management counselors that our patients also have access to. Okay? It is a physiology-based and physician-guided program. So someone who has studied the heart's coronary perfusion mechanisms, who has studied coronary artery disease, and who knows how to manage this disease actually guides this program. Well, lucky me, that's me. So that's what I went to school for. That's why I'm here. That's part of my job as being over the cardiac rehab program, is working with each patient on an individual level and an individual basis and setting their aerobic exercise goals based on their current capacity, but also based on their heart's capacity and the medications that they're taking. This is also overseen by a physician. We do have a physician director who monitors all cardiac rehab activities to make sure that the patients are receiving what they need when they need it and that they're receiving it safely. Okay. Telemetry monitored exercise is provided. We do continuing education both for staff and patients. And we also do discharge follow-up by way of telephone calls, the cardiac rehab's maintenance program as well. Okay. Eligibility for patients to join the rehab program, you have to have had some type of coronary event, stable angina, PTCA with or without stenting. So again, that's that angioplasty or that stent procedure. Heart attacks, open heart surgeries, valve repair and replacement, heart transplants, heart failure, and the newest addition is LVAD, which is left ventricular assistive device. So patients whose heart function is to the point that it can no longer sustain life, they can actually put a pump in your left ventricle that does that work for you. We do rehab services here for that particular population as well. Patients who are interested in enrolling in the program or have any other questions about enrolling in the program, it is a physician's referred program, so you do need a referral from your physician. It is also an insurance billed program, and that's generally something that we handle on a case-by-case basis. And always remember, be nice to your heart. It's the only one you've got. Do you guys have any questions at all? And thank you for your time. Thank you for your attention.